Hard to bag somebody when they're still breathing. I mean, you can try to time your breathing with them, but the other thing, even I think a bigger thing, is gastric insufflation, so filling up the stomach so they yak. So there's a big difference between somebody who's experiencing some adrenaline squeezing that bag versus a mechanical ventilator who's giving 60 liters per minute versus 250 liters per minute. I think you can maybe reduce that gastric. Yeah.
It's really hard though. Like, how many times have you seen someone, you get ROSC, and like if you look at how often someone's breathing, it's very common for them to be getting 30 breaths a minute. That's just it's inherent. And honestly, without a metronome, and I'm serious, like there are resuscitationists who are like, I put my metronome out and it's set to 12 a minute. Like without that, you're unlikely to actually get close to that because your internal clock is wrong. It's fried. I mean, there's a lot of folks that you say, we got a tube right now, that the real answer is we got a tube soon, but not in the next 60 seconds, that we need to tube in the next 10 minutes maybe, or 20 minutes, enough time to do a lot of the stuff that we're talking about. But as Rich mentioned, you don't want to overcome the tone of the esophageal sphincters, and that's where NIV is more likely to safely do that, because if you're squeezing the bag, it's really hard to gauge exactly how much pressure. The machine is much better at that. Also in the community setting, because we have the privilege of often, if we need it, we can have 3 or 4 physicians in a room, counting attending and the residents, we can just pile in there. If you're getting all this other stuff ready, at a lot of community shops, you don't have a bunch of extra hands. So you're getting your intubation equipment ready, you're setting up the ultrasound machine yourself. It's great to be able to offload that to a machine to breathe, to give those perfect breaths that are timed appropriately. It can be handy, because if you have a trauma patient that you need to tube and put in the chest tube and you want to do a fast exam, like all these things are you. There's no one else there. So it can be nice to offload that and you're not the one squeezing the bag.
A bag valve mask attached to oxygen is not 100% oxygen, especially if you don't have a PEEP valve. In a spontaneously breathing patient, they're entraining a fair amount of, even if you have a good seal, you're still getting maybe 40%. Bag valve mask by itself in a spontaneously breathing patient is useless. You shouldn't be doing it to any patient, anytime, okay? It's just, I would say there's no situation where a bag valve mask, spontaneously breathing patient, you're much better off having them on a 100% quote unquote non-rebreather and nasal cannula.
But in this situation, you're talking a lot about venous return and the changes in venous return that are causing a patient to code.
So,
if you have PEEP, a constant PEEP, which I assume you would with a.
Well, you don't. So there's no PEEP on a regular valve.
I assume you would with a non-invasive ventilation. You're not going to have that at all when you're bagging, because they're taking the bag away in between breaths. Yeah. Even if you have an auto PEEP valve, most of the time they're not going to hold the bag firmly to the face. So wouldn't it be significantly different in that situation either way?
Now, one thing I have done is do the nasal cannula at 15 liters, have a PEEP valve on a BVM, and then do a 2-hand seal to let them spontaneously breathe, in which case you're simulating NIV without the machine and just having them spontaneously breathe.
Which is, I agree. So that's the point, I think, and I agree completely with what Dan said, is if you have your nasal cannula on and you're not bagging, but you're holding the face mask on and they have a PEEP valve, you're simulating NIV in a CPAP situation.
Well, we are, but I think Dan may have either said this or started to say this. NIV in the emergency department, I think, where you have one-to-one nursing in the resuscitation bay, at least for the first part of the patient's resuscitation, I don't think altered mental status is a contraindication of putting that patient on NIV. I think you should put them on NIV to temporize things, to begin your resuscitation. Now, if you get yourself in a situation where now you're having to dedicate one person to holding the mask on their face, now you've taken 2 hands out of the resuscitation. That's why I like the NIV. I know our team may say, well, they're too altered to do that, but we're watching them. If they start vomiting, we pull it right off and we can suction them out. We can roll. So let me just say one thing. We went way out in the weeds, and I know resuscitation fog is a real thing. You got a lot of things going on. You got decisions to make, lots of distractors, and some of those decisions are serious life-altering decisions for the patient. If you have to intubate, you have to intubate. That remains the same. I just want you to keep in the back of your mind those 5 or 6 things. You can use your ultrasound to help parse out those differentials, and if you got the time, try a little resuscitation before you intubate that patient. That's, I don't want you guys to say we need to be doing ultrasounds and all this other stuff before we intubate this patient. If you have to go, you have to go, all right, and you deal with the consequences afterwards.